to the 3-episode limited edition Pods Heal Heals podcast. I'm Diane Ashcroft. You might know me as the Potty Purple Pod because I'm a bit bonkers and I love purple. And I'm a podiatrist. So why am I talking to the 3 guests I've selected? Ian Sadler, Andrew Ayres and Ben Lumley. They were the 3 expert podiatrists that helped me and 120 other podiatry colleagues get a better understanding of plantar fasciitis, heel pain and how to treat it at the 2 training events that they held in 2018. At those events they focused on the best practice modalities that we should be using in treating plantar fasciitis and heel pain, all backed up by research and data. In February 2019, a bunch of us from that training collaborated on an awareness campaign which we called Pods Heal Heals. It was a great success in achieving our goal in helping people understand more about the heel pain and plantar fasciitis that they thought they had and what they could do about it. We're running another Pods Heal Heals awareness campaign in 2020, and that's why I wanted to talk to these 3 key podiatrists for this podcast. Hope you enjoy it, and I hope it helps you understand heel pain and plantar fasciitis better. Let's talk to my 3rd guest, Ben Lumley.
Hello there. So my name's Ben, as you said. I work up in Cumbria as an advanced practitioner musculoskeletal podiatrist. So I see only MSK conditions of the foot and ankle. Quite a few of those are complex heel pain presentations. So the ones that don't respond to usual conservative measures or there's a query of diagnosis. So physios, podiatrists and GPs all refer in to me when they need some help or a second opinion.
Fantastic. So given that you're in the NHS, does your service still, I was about to say, suffer with the pattern, if you like, of seeing quite a few patients that come in with an initial diagnosis of plantar fasciitis that actually turns out not to be?
Oh, all the time. So either be that they've only had a quick appointment and not had a thorough assessment, or they've gone in saying, look, I've been diagnosed with plantar fasciitis, I'm not getting better, or they've self-diagnosed with plantar fasciitis and they're not getting better and they get referred into our service. So we do get a bit of a mixture. Some do have plantar fasciitis, some don't, and some have been given a good diagnosis, appropriate assessments, and unfortunately haven't responded to care, but quite a lot have just been, because it's heel pain, the assumption is that it's plantar fasciitis, but sometimes it's not.
What kind of proportion turn out not to be, would you say?
I'd say probably around a third.
Yeah, that's quite a significant number.
Yeah, well, a lot of the simple plantar, well, I say simple, not simple, but a lot of the more banned or plantar fasciitis go to core services, and they get better. Ultimately, it's a self-limiting condition. Well, the literature still suggests that, so quite a lot of those do resolve without any healthcare provider intervention.
Yeah.
But we tend to get the more unusual heel pains.
I'm going to say, if you're telling somebody that's had plantar fasciitis or heel pain of whatever cause for 5 years that it's a self-limiting condition,
yeah,
I guess they're not going to believe you.
No, they're not. And that's sometimes because like plantar fasciitis isn't just plantar fasciitis in isolation, or it was never plantar fasciitis in the first place. It's not always that clear cut.
Tell me about it.
Yeah.
So, can you tell us about the most challenging case of heel pain that you've actually helped to resolve?
One was probably the patient who did have plantar fasciitis, but had quite not great management initially. So she came into initial appointment on crutches, which is immediately raises an eyebrow because you think, well, this isn't typical for a patient walking in with plantar fasciitis. She'd had this real sense of fear and guarding put into her. She had this real belief that every time she put her foot on the floor, she was causing structural permanent harm.
Oh.
So actually taking a lot of time to talk to her, reassurance, assessment and diagnosis, and we spent a lot of time just talking to her and understanding how this was impacting on her and trying to breaking down those barriers and explain to her that actually this can be managed. And it took quite a variety of treatment options. So we really worked with her on things like getting her back walking without the crutches, engaged with her rehab. Weight loss for her was quite important. all these kind of things had a big impact. So Slimming World referrals and things like that all actually made a real positive impact on her.
Wow, that sounds like your service really does focus on a complete wraparound care package.
Yeah, because we liaise closely with quite a lot of different professions, from physiotherapy to sometimes persistent physical symptom service. We have quite close ties with, to liaise with GPs, rheumatologists, orthopedic surgeons. Done a couple of neurology referrals, these type of things. So actually, we have quite good working links. We're quite really fortunate up in Cumbria in that we have, in my job role, that I can refer to direct to a variety of services.
Well, I'm sure you're a major influence in making that happen.
Stubborn. Persistent, I think, is probably the word.
You don't take no for an answer.
No.
But your patients are benefiting from that.
Yeah, absolutely. It allows, so because I spent a lot of time going in, I went and introduced myself to all the other professionals in and around the area. So I spent time in rheumatology, went and introduced myself to the orthopedic surgeons, set up joint clinics alongside them, do a lot of in-service training for physiotherapy and podiatry departments. And this has really helped build these close links. And I think that's the best way to be. There's no shame in referring on or engaging with other services. It actually makes you a better practitioner by doing that.
It certainly does. So talking a bit about heel pain again, and you were saying like 30% of them aren't plantar fasciitis that come in that are. Tell us about some of those other conditions that you've had to identify and what they've turned out to be.
So I've had 3 tarsal tunnel syndromes recently. One was a ganglion with impinging a tarsal tunnel. One was flexor digitorum longus tenosynovitis.
Wow.
So an inflammation of the tendon which was causing neuralgic heel pain, like this nerve type pain in the heel. And the final one was called a schwannoma, which is like a nerve cell tumour.
A schwannoma?
Yeah, it's like a tumour on the tibial nerve. Thankfully, we got an opinion from the sarcoma team. Happy that it was completely benign. So she's going to have it excised and tarsal tunnel decompression.
Wow. That's a good one, isn't it? How did you finally diagnose that?
Through MRI, because she had more tarsal tunnel type symptoms, so I got an MRI done. Any of my patients with tarsal tunnel type pain, I tend to MRI them, because one of the causes of tarsal tunnel syndrome is a space occupying lesion. And
that's only going to show up on an MRI?
Yeah. Well, you could probably get it on ultrasound scan, but when you're considering that, I tend to get an MRI done, because often they're looking at surgical targets. So our local surgeon team prefer to have an MRI to see where it is and for surgical planning as well.
Ah, good. Well, it makes it all efficient. I'm glad you're spending my tax dollars well.
Oh, absolutely. But other causes we tend to see are things like we've had a couple of stress fractures with calcaneus. We've had like heel fat pad edema. Had a giant cell bone tumour with a calcaneus.
A giant cell bone tumour?
Yeah, a benign bone lesion, usually benign bone lesion, but that patient it eroded quite a lot of the calcaneus. Patients have quite complex surgery done in the end through the sarcoma team out in the northeast at RVI.
You make it all sound very matter of fact.
Well, I have access to imaging, so it makes my life a lot easier sometimes.
So if you're going to have heel pain, have it in Cumbria, because they've got all the resources there.
Well, there are plenty of other good people. I'm really fortunate that I've had really senior podiatric surgeons, advanced practitioners, very experienced podiatrists who I regularly message for help, and they provide a great deal of support, and wouldn't be able to do my job without them.
It is great having great connections in this business, isn't it? And reaching out to people that are at the cutting edge of it, really.
Oh, totally.
So, heel pain. You love it, don't you? Tell me what you love about treating heel pain.
I like the complexity of it, because there's so many contributing factors that can present as heel pain. I like the screening process, the work, trying to pin down a diagnosis. And sometimes it's not always easy. Sometimes it's a bit more obvious, a bit more classic presentation of plantar fasciitis, but sometimes it's not. And I like working through that. So you're not just considering the heel, you're considering potential underlying systemic factors, such as ankylosing spondyloarthropathies. There's things like reactive arthritis and a whole host of things that can present as heel pain. So actually, it's quite complex. It's varied. and it's really interesting.
So you're on the lookout for any of these inflammatory disorders that can turn out to be something completely different.
So it can be really simple, basic history taking, but having that awareness of that, you can get people diagnosed earlier and help them more. Like patients with ankylosing spondylitis can take years to get diagnosed, and as effective treatment early on, they have much better long-term outcomes.
Explain a little bit more about ankylosing spondylitis for anybody listening that doesn't know what it is.
So it's one of the rheumatological conditions that can present as like sacroiliitis. Tends to be younger males that have it, genetically prone to it. One of a whole host of weird and wonderful conditions that rheumatologists treat. So any podiatrists who are listening, I'd recommend spending some time with your rheumatology department at some point. Great learning opportunity. And it can lead to enthesiopathies, tendinopathies, and like when you get these chronic tendinopathies that are not responding, and you've got a patient with youngish male with sacroiliac pain, because it tends to be more common in males, can get it in women as well, but more common in males. If you've got those patients with that type of pattern, I think it's always worth screening for and investigating a little bit further.
Does that show up on a blood test?
It can. Some patients are HLA-B27 positive, but some are not. But MRI scans of the lumbosacral region will show up inflammation in around that area.
And you talking about history taking there, are there any particular key questions that kind of get you suspecting that maybe, your average Joe podiatrist like I am should be asking?
Yeah, so if I had a patient coming in with morning joint stiffness of more than 30 minutes with a history of IBS, colitis, eye infections, family history, these kind of things would be raising my suspicions further. Nice guidelines have been updated not that long back, and they show like a really simple screening questionnaire for that. So I would encourage all podiatrists to read that as well.
Good advice. Okay, let's go to the polar opposite then. Is there anything that you actually hate about treating heel pain?
I think sometimes people don't take enough time to question the diagnosis, just because heel pain is plantarfasciitis, and that frustrates me a little bit, because these patients who do have more sinister pathology or underlying systemic pathology could have been picked up at an earlier opportunity, or their management has not necessarily been ideal. Right. So just been given a pair of orthotics and told to go away, or not followed up, or not rehabbed in conjunction with giving one treatment modality.
And why do you suppose that is?
I think sometimes when you've got quite a limited tool of treatment available to yourself, you tend to rely on those tools. So the saying of, if you've got a hammer, all you see is nails.
I get you. So, apart from seeing a podiatrist, what would be your singular piece of advice to somebody who's currently suffering from heel pain that's not resolving? So
I would make sure you've been given a reasonable diagnosis from someone who's experienced in assessing and management of lower limb MSK pathologies. Being consistent with your rehab. If you've been given a treatment plan, be consistent with that. Always helps. And if it's not responding to one form of treatment, try and understand why and ask for an explanation and see what other treatment options are available.
But your key piece of advice is to see somebody who really knows what they're doing, musculoskeletal assessment-wise, to be able to get to that accurate diagnosis.
Yes, ideally a podiatrist.
Not that either of us are biased at all.
No, not at all.
Oh, thanks so much for talking to me, Ben. I know you've got a busy day.
No.
And are you still doing your MSc or have you finished now?
No, still doing my MSc, working through my dissertation now.
Oh my word. So studying hard, working hard, and you've got a little one that you've been wrestling with to get to bed tonight. So I really do appreciate you taking the time to talk to us tonight and share your experience of how you handle heel pain.
No worries at all. My pleasure. Thank you very much.
Oh, thanks a lot, Ben. Take care. Bye-bye now.
I want to thank all my guests, Ian, Andrew and Ben, for answering my questions on this year's Pods Heals campaign. And if you're suffering from heel pain and you want to know some more answers about the help that's available out there for you, check out the hashtag Pods, Heal, Heals, and you'll find lots of resources there. Thanks for listening. Bye for now.